So technology, as we have seen, can definitely improve the implant position, alignment, and soft tissue balance. It can reduce the outliers, as has been shown beautifully in the morning so far. Thereby, it can improve outcomes. But if you read through the literature closely, that it improves outcomes is not yet decisively proven, but it would seem like that. So navigation can be a large console navigation, imageless navigation, accelerometer based, gyrometer based. Various forms of navigation are available. The Journal of Arthroplasty is thought to be the fountainhead of knowledge about knee arthroplasty and hip arthroplasty. So if you read through this symposium written in 2018 as to the current role of computer navigation in total knee arthroplasty, they have raised three fundamental questions. What is the alignment target? What is the best way of achieving that? And does that guarantee better patient-reported outcome measures or reduce the revision rates? So the alignment target, as we know, classically has been mechanical. Currently, we are talking about kinematic, functional, personalized, and various other alignment targets. The discussion arises because this plus and minus 3 degrees from the mechanical axis alignment. There was an article by Keith Berend where they looked at more than 3,000 cases, followed them up for 2 to 14 years, and found a 17% greater failure rate when it was not aligned in plus or minus.
Yeah, we can do that. Yeah,
the mechanical alignment target. And this rose to 168% failure rate, greater failure rate in obese patients, BMI more than 35. But this concept was challenged in 2010 by Sebastian Parrott, who is here with us, and Dan Barry group, where they followed up 398 knees for 15 years and found that the failure rate was similar in both groups, whether they were aligned or what you would say malaligned. That means the alignment was falling out of the 3 degree outlier. So enough studies to show that navigation will improve accuracy and precision of component alignment, but not enough evidence that it improves outcomes or reduces revision rates. So value in healthcare is benefit over cost. And there are some papers which say that navigation, if the cost can be reduced by over 50%, that is why I only navigate the femur, then the value is there. So simplified navigation, only distal femoral and proximal tibial cuts, not for rotation or balancing, and results show as good results as full navigation. Restricted femoral navigation, as you saw in the morning, tibia is subcutaneous, so you can feel the landmarks yourself. Do not use navigation for rotation and balancing. And we published this paper way back, I think in 2014, where we showed that only limited femoral navigation or restricted femoral navigation can be as effective as full navigation, and the coronal alignment of the femoral component can be better with restricted femoral navigation. This is published in the Journal of Arthroplasty, and I still follow this. PSI reduces the surgical time without losing accuracy, but obviously there are costs in making these blocks, and blocks have to be pre-ordered and are case specific, and literature is currently divided about its use. If you read this paper where they looked at PSI with conventional and CAS, they found that PSI and CAS can both improve the alignment similarly. If you look at PSI versus conventional instrumentation, perioperative and cost differences, the cost of PSI can be offset against less OT time and productivity. When you look at PSI in obese patients, it was found that it is not cost effective for high volume surgeons. Robotics is the flavor of the probably decade, because it can allow you to do a virtual surgery before the actual surgery. And before coming down here, we were just doing the virtual surgery on the case that we are just about to perform. It can give options, and one can choose the most appropriate option. It can execute the chosen path plan reliably. Bone preparation, alignment, implant position, soft tissue balance, all can be reliably improved. But currently, all these robos are implant specific, can be image based or imageless. It requires spins in the femur and the tibia. There is an added time, there is an added cost. Whether patient reported outcome measures improve with this, what do you do with the patella and the cementing technique, all this still remains in the hands of the surgeon. So when you see this article, pros and cons of a balanced view of robotics in knee arthroplasty, the evidence seems to be that it is more useful in partial knees than in total knees. When robotics was compared with manual total knee arthroplasty, it was found that there wasn't a huge deal of difference, but there is a higher surgical time with robotics and increased cost. This is in people who are doing a huge number of knee replacements. When you look at robotics in partial knees, this is the promising technology, but obviously cost is a factor, time is a factor, but it can give you greater accuracy of implanting the components. What is my take on all this? Friends, I believe that times are changing. Patients are more aware and patients are more demanding. So preferably, we all should have access to technology. We may become selective users depending upon what the case is, but we also need to be cost sensitive, because we are not just working in major corporate hospitals. We have to be catering to the whole country, and this surgery happens in nursing homes and smaller hospitals as well. There is a great book by Spencer Johnson, which is called Who Moved My Cheese, which says that change is the only constant in life. And it also tells you that we have to smell the cheese often so that we know when it is getting old. Whatever we may be doing, the techniques may be getting old. I would say to this that aged cheese can be better as well. Whatever we are doing, we can still continue to do if we are getting better and better at it. And we should be focusing on outcomes and patients rather than only techniques and technology. I thank you for your attention.